First is STI. So few terminologies are there. First is RTI or reproductive tract infections. Another terminology is sexually transmitted disease. Another terminology is STI or sexually transmitted infections. So you must be wondering why so many words are used. Now what does RTI means? Reproductive tract infection. It basically means any kind of infection within the reproductive tract of both males and females. Any sort of infection. It may be transmitted sexually, may be transmitted non-sexually. Any type of infective disease in the reproductive tract is called as reproductive infections. Now, in women it would include obviously the external genitalia, cervix, uterus, fallopian tubes and the ovaries. And in the males it will be external genitalia, urethra, prostate, seminal vesicles. Okay. Now, then what is STD? STD stands for sexually transmitted disease. That means all those diseases which are transmitted by sexual intercourse. It may or may not be a reproductive tract disease. It may be a different disease altogether. For example, HIV. HIV is a STD because it can transmit through sexual intercourse. But does it infect the reproductive tract? No, it's basically a systemic disease. Furthermore, there are different routes of transmission of HIV other than sexual route. Okay. So when we say, that means it's a sexually transmitted disease that cause microbes that are passed from one person to the other via sexual contact. Then why is the term sexually transmitted infections are concerned? Well, first of all, you must understand any disease which either transmits through sexual route or affects the sexual organs, internal or external, carries a social stigma in any society, any country. Because of the use of the word STD, it carries significant social stigma. WHO has recommended the use of the terminology STI or sexually transmitted infections to get away from the stigma of STD and also to incorporate other reproductive tract infections which are normally overseen or not given value in the earlier construct of STD. Okay. Now, when we are talking about STI, that means all the infections which are transmitted sexually and it affects the reproductive tract organs. Okay. It is actually approved by WHO. Now, let us look at this diagram. You can see that when we say RTI, that means reproductive tract infections. Now, look on this side of the table. First is disruption of normal vaginal flora, Candida vaginitis. Okay, it could be due to hormonal imbalance, it could be iatrogenic. There are many causes. That is a type of infection, but that is not spread sexually. Again, postpartum infection or intrauterine devices which might get infected. This is a reproductive tract infection, but not sexually transmitted. Okay. Now look at this one, HIV, hepatitis. These can transmit through sexual route, but they are not reproductive tract infections. And there are some diseases like gonorrhea, chlamydia, syphilis. They are reproductive infections. That means they can infect reproductive organs, external or internal part, and are transmitted sexually. I think now the concept is pretty much clear to you. Okay. So when we are talking about STI, we are considering all this. Okay. Now, why STIs are important? The predominant population which suffers from sexually transmitted infections are females. In a study, it has been shown that Women with reproductive tract infections, if 100 women are there, out of which only 50% will be symptomatic. And among them, only less than 40% will actually seek treatment. And if you go on further, you will find out that correctly treated, and another important part is the partner treatment, from whom the woman actually gets the infection. So less, almost zero. Why I am showing you this? Because for proper management of sexually transmitted infection, you need to treat not only the patient, you need to treat the partner of the patient, and also because end of the day you need to stop the transmission. Okay. Now, why? First, to prevent complications, we will look into the complications. Then we need to stop the spread of the disease so that the same person does not get reinfected or spreads the infection from another person to another person, or importantly you need to also educate the patient. Okay. Now, what were the types of STI, RTI? The types of the disease, I think most of you are acquainted because the classes are already there. Syphilis is the type, then gonorrhea, chlamydial infections, trichomonas, chancroid caused by Haemophilus, genital herpes, genital warts, HIV infections, hepatitis B and C, donovanosis, lymphogranuloma, venereum. These are the important diseases. Some of the not so important but still significant diseases including molluscum contagiosum, genital scabies, and pubic lice. Okay. Now, patients with STI will present with various types of signs and symptoms. Okay. If we look at them, common symptoms in men are urethral discharge, genital ulcer or genital itching, and swelling or pain with swelling in the testes. In case of females, we can find vaginal discharge, genital itching, unusual or heavy bleeding per vagina, dyspareunia or bleeding after intercourse. Dyspareunia means painful intercourse. Then lower abdominal pain and vaginal candidiasis. Some of the common include blisters, ulcers, burning pain during urination, itching, jaundice, and warts or bumps. Patient might come, there is small swelling with the bumps. Not at all painful, no reaction, only small bumps. Warts will present like that. Other, if systemic infection is there, we can find flu-like illness, red ulcers or red nodules. These are the common symptomatology. Now, where does the patient get this kind of infections? Look over here. It can be either an endogenous infection, like what is seen in bacterial vaginosis or candidal vaginitis. The organism is present within the patient's body. Because of a hormonal imbalance or use of various drugs during treatment for other diseases, it can cause. Other would include like STI in sexual partners, or it could be iatrogenic. I have already said, like intrauterine infections. Iatrogenic means during treatment of any other cause. Okay, any operative procedure has been done, it can get infected, or even contraceptive devices like intrauterine devices. Now, you must understand that when we are talking about syndromic approach, that means we are trying to treat the patient based on the syndrome rather than looking at an exact cause. For that, we must know what are the predominant syndromes, which is seen. The first syndrome would be vaginal or urethral discharge. Okay. So, in females it could be vaginal or urethral discharge, and in case of males it will be urethral discharge. Important diseases would be gonorrhea, trichomoniasis, chlamydia, and in case of females bacterial vaginosis and candidiasis. Okay. Another next important would be genital ulcers and buboes. Bubo means swelling of the inguinal lymph nodes. Okay. As a physician, you will be able to understand it is the swelling of the lymph node. but the patient obviously he will come or she will come and complain to you that there is swelling in the inguinal region. It is called as bubo. Now, some of the diseases will present with genital ulcer and bubo. This include chancroid. Please learn to differentiate between chancre and chancroid. Chancroid is caused by Haemophilus ducrei and syphilis. Another important is LGV or caused by chlamydia trachomatis. They will present with genital ulcer with or without swelling of the inguinal region. Other important would be donovanosis and genital herpes. In females, another important syndrome is lower abdominal pain, that is suprapubic pain. Other important symptoms in the same would be dyspareunia and unusual or heavy bleeding. These all indicate what is known as pelvic inflammatory disease, which basically means infection of the internal genital organs of a female. So, normally you will find pelvic inflammatory disease is seen infections with Neisseria gonorrhoeae, chlamydia trachomatis and anaerobic infections. Generally, anaerobic infections are more commonly seen if a procedure is being done. Iatrogenic or accidental or sometimes unscrupulous activities can lead to anaerobic infection of the internal genital organs. In males, another important would be scrotal pain. This indicates either epididymitis or orchitis. Orchitis means inflammation of the testis, generally seen with Neisseria gonorrhoeae or chlamydia trachomatis. Okay. There will be other causes of swelling of testis with pain, like it can be seen even in mumps or say a torsion of testis, but we are not considering them in this context. Next is genital skin conditions. Human papilloma virus, I think you have heard about it. It causes cervical carcinoma. Few strains do cause cervical carcinoma, but most of the other strains will cause what is known as genital warts. Warts are small swelling of the skin. They do not have any pain or itching, just predominantly small swelling. Another important is molluscum contagiosum. It is caused by pox virus. It will cause umbilicated skin lesions. Then pediculosis pubis. Pediculosis pubis means pubic lice. One is body lice, another is pubic lice, or sometimes also called as crab infection. Okay. And finally is genital scabies. Genital scabies means the patient is infected with has the scabies, but predominantly located in the genital regions. Both of these are more commonly associated with people with poor hygiene, especially in homeless people. Based on all these symptoms, we have a national policy for sexually transmitted disease. And under the National AIDS Control Organization, they have classified into these conditions. What are these conditions? Urethral discharge, vaginal discharge, genital ulcer, inguinal bubo, lower abdominal pain, scrotal pain, and skin infections. Okay. So, whenever a patient comes, we need to assess what are the signs and symptoms and then categorize them. What is the predominant complaint of the patient? Is the patient predominantly comes with a discharge urethral or vaginal, or patient is coming with a lower abdominal pain, or the patient is coming with genital ulcer? Okay. Now coming to complications. Why this is important? Because we need to avoid complications. Now what is the main purpose of a reproductive tract? Is the propagation of the population. So any kind of infection, especially in adolescent and reproductive age group population, will result in a very severe consequence called as infertility. And the next important would be other diseases including carcinoma of the genital organs. Okay. So this is a checklist that is given by the National Health Program, how you should approach a patient with STIs. You can find it there. Now, the main gist of all this approach is, first you need to, after taking proper history, including contact history and sexual history. This is very important, and normally it's a very sensitive issue. Most of the people will not be very comfortable talking or giving an elaborate history, sexual history to the doctor. So first you must gain the confidence of the patient, make him or her understand the importance of this, and then elicit the history. After taking the history, you must examine the patient. First is general examination like all other patient. Then you need to inspect the genitals, examine the external genitalia, and in case of females, you need to do what is known as speculum examination and bimanual examination. Speculum examination is, with the use of a speculum, you inspect the vagina and the cervix for ulcers or lesions, and in bimanual examination you inspect whether there is any pain in the internal genital organ. Okay. However, you should always keep in mind, when we are taking history and examination, we are basically guided by the signs and symptoms. Many a times the patient may be asymptomatic without any kind of finding. So if you do not have any finding, either in history or in examination, that does not rules out that the patient has got no STI. Now, what should you do? Remember the 6 C's. First is counseling and education of the patient. One of the patient comes to you, whether he or she is having any infection or not, you must counsel the patient for having a proper sexual habit. Okay. And further educating the patient and patient partner. Then contact tracing. If you are suspecting the patient is having any kind of sexual transmitted infection, from whom the patient will get the infection? Obviously from the sexual partner. You need to trace the sexual partner. Obviously contraceptive promotion, especially condom. Then you must counsel and reinstate the idea that the patient must continue with the treatment till the patient is cured. Many a times patient will come to the doctor, get the treatment, initiate the treatment process, and then give up. Finally, you must also follow up the patient to ensure that the patient is cured. If the patient is not cured, what will happen? He or she will infect other people also. Okay. Now, when I say treat, follow up, and ensure the patient is cured, it's not only for the patient but also for the partner. Partner may or may not have any kind of sign symptom, but you need to treat the partner also. Okay. Now, approach to any disease may be 2 ways, either etiological approach or syndromic approach. What is etiological approach? We take the history, we do the specific required clinical examination, and we try to test by various investigation, laboratory, radiological, etc., etc. Why? To find the exact etiology of the disease and treat the specific disease. However, we are here advocating for syndromic treatment. That means we are not looking for a one single etiology. If the patient comes with a set of syndrome, we think this is the syndrome, we need to treat these diseases. There are 2 reasons. First of all, for etiological diagnosis is more laborious. First of all, it is not very conducive to use in the field. Field means when you have to cater to a huge population. Exact diagnosis for every person becomes very difficult and very time taking. Whenever something takes a very long time, what will happen? You will lose the patient in the follow-up. Whereas in syndromic approach, you are not trying to stress on the definitive diagnosis. You are trying to treat based on the syndrome. So the time duration is reduced. You can actually treat a large number of patients in a very small period of time. Furthermore, many a times the patient may be infected with 1 or 2 diseases. Okay. most of the disease will have the same route of transmission, that is co-infection. If you look for an exact etiological diagnosis, you may find one type of infection, but you may miss. But if you go by the syndromic approach, you are treating all the infections which contribute to a particular syndrome. Okay. This is the reason why the government of India advocates for syndromic approach of treatment of sexually transmitted disease. A few more important things that you should know after education and counseling the patient: you must advise for sexual abstinence during the treatment course. Obviously, during the treatment, the patient is not cured. The patient is cured after the treatment is completed. So, for during that timeline, the patient should continue abstinence, sexual abstinence. Next, consult the patient and ask for his consent. Other diseases like HIV, hepatitis B, these are systemic infections which spreads via sexual route. So, if a patient has a sexual transmitted infection, there is a higher chance the patient might be infected with these diseases also. So, whenever you find a patient is having any sort of sexual transmitted infection, always test for this disease. Okay. Consider immunization for hepatitis B and follow up the patient. Now, let us look at some of the syndromes briefly. First is urethral discharge, or the patient may come with dysuria. Now, what are the common organisms causing? Neisseria gonorrhoeae, chlamydia trachomatis, and trichomonas vaginalis. So, you need to take the history of them, look for whether there is any active discharge or not. Then we need to get a laboratory test done. And normally, most of the time, you will not have the facility or the scope of confirming the diagnosis. But if you do have, you must know what to do. First is gram stain of the examination, that is Neisseria gonorrhoeae will show gram negative diplococci. Culture can be done, however, it is a tedious process. Most of the time, you will not have the scope or the opportunity to do the culture. But coming over here, the most important is this one: tablet cefixime 400 milligram orally and tablet azithromycin 1 gram orally. Now, cefixime is targeted for, look at the organisms: gonorrhea, chlamydia trachomatis, and trichomonas vaginalis. Neisseria gonorrhoeae, for that we need to give beta-lactam, that is a cefixime is given. For chlamydia trachomatis, we are giving azithromycin. And if it is trichomonas vaginalis, we are giving this seclinada. Okay, we are giving all the three drugs. Have you understood? We are targeting these three drugs. Similarly, there are specific guidelines for management of the partner, and especially if the partner is a woman and pregnant, there are specific guidelines. I am not going into the details, you can go and read. I am just showing you the approach. Now, follow up after 7 days, and if the patient is not cured or has signs and symptoms of reinfection, you may retreat them or may even refer to the referral center. Next is scrotal swelling. Scrotal swelling, again, chlamydia gonorrhoeae, chlamydia trachomatis and Neisseria gonorrhoeae are the predominant cause. And if we look at the treatment, we have the same. Next is inguinal bubo, or swelling of the inguinal lymph node. Over here, the causative organism will be chlamydia trachomatis and Haemophilus ducreyi. For that, the treatment would be doxycycline 100 milligram daily for 21 days with azithromycin or ciprofloxacin. Similarly, you need to, now coming to genital ulcers. Now, what would be the causative organism? Treponema pallidum causing syphilis, Haemophilus ducreyi, chancroid, Klebsiella granulomatis, chlamydia trachomatis, and herpes simplex. Okay, there are spirochetes, there are bacteria, and there are viruses. All will cause genital ulcer. It may be painful ulcer, maybe painless ulcer, maybe bleeding ulcer, maybe non-bleeding ulcer, whatever is there, you need to treat all. Now for that, like you need to investigate like RPR for syphilis, microscopy can be done. Now look over here. If we are suspecting all these diseases, what would be the treatment? For herpes simplex, we are giving acyclovir. Okay. To target syphilis, we have to give penicillin, and for Haemophilus decree, we need to give azithromycin. Okay. Thereby, we can treat all the diseases which cause genital ulcer. Obviously, test for HIV is mandatory. Similarly, in case of vaginal discharge, it could be vaginitis, trichomoniasis, cervical herpes caused by Neisseria gonorrhea, chlamydia trachomatis, trichomonas vaginalis, and herpes simplex virus. This is a vaginal discharge. All these organisms. So, what would be the treatment? For trichomonas, we need to give metronidazole or seclinidazole. Seclinidazole is preferred because a single dose is sufficient. For syndromic approach, you should also consider the pill burden. If you give for a prolonged period of time, most of the time people will not complete the course of the drug. However, if you can give a drug which a single dose, that is preferred. That is the reason why seclinidazole single dose can be given, or if tinidazole, it is given twice a day. Other will be cefixime and azithromycin. And if it is case of herpes, we need to give acyclovir. Next, lower abdominal pain. Infections associated would be Neisseria gonorrhoeae, chlamydia trachomatis, and now very important are anaerobic infection. So over here, look over here. We need to give cefixime and metronidazole for 14 days. It is targeting the anaerobic bacteria. Now we need to give for 14 days, along with other drugs for chlamydia trachomatis and Neisseria gonorrhoeae. Other important aspect would be oral and anal STI. These are also very commonly seen, and obviously there are many medical legal aspects of this. I am not going to cover, especially if the person is under 18 years of age. It might indicate that is sexual offenses, so it will have other implications. I am not discussing all those parts, but what you need to remember that all these organisms can also cause anal and oral ulcer if unnatural sexual practices are being done, and it involves the same. Management would be to consider all those ulcers and putting them in the existing syndrome. Okay, like if there is unprotected ulcer, there is anal discharge, we can, if there is discharge, we can put in a urethral or in the category of the urethral discharge, because the infections which cause urethral discharge will also cause in the perianal infection in the perianal region leading to anal discharge. Now, if there is ulcer seen in the perioral or anal region, that means it will be, we have to categorize them in the genital ulcer category. Similarly, if there is diarrhea, blood in stools, then we need to consider them under the lower abdominal pain category, because now we are considering inflammatory disease. Okay, based on that we have to categorize them, and then after categorization we have to follow the same syndromic approach. Anogenital warts can present like this, and obviously human papillomaviruses, there are cosmetic treatments with podophyllin, etc. And there is molluscum contagiosum. Typical, these are the lesions, raised umbilicated lesions can be seen. They are highly contagious, so you need to counsel the patient not to itch with the fingers, because it can spread by itching from one side to the other. It is caused by pox virus. And next comes is pubic lice caused by pityriasis pubis. Treatment is same with permethrin like body lice. And finally is scabies infection. It can be there in the genital region. What is important is what is important that these are cutaneous disease. Still, you must advise the patient not to have any kind of sexual activity before completion of the treatment. Okay, even though it's just a cutaneous manifestation, it can spread from one person to other. Okay. So all what I have said till now can be actually summarized in this chart. This is the chart given by the National AIDS Control Organization by the syndromic management. And if you see, there are color coding. Specific sets of medicines are packed in different packages which are color coded. Based on the syndrome, we give the patient one packet. Have you understood? Now let us look at one of the syndromes and which package that we must provide to the patient. First is urethral discharge. Now look over here. Urethral discharge, you have understood what are the diseases, organisms which cause urethral discharge. Now what would be the drug? We need to give azithromycin and cefixime, single drug. So why single drug? So we can monitor whether the patient is actually taking the drug or not. The patient has to take this drug in the clinic itself. If the patient has taken in the clinic, we can monitor the therapy. And for that, kit number 1, that is the grey colored kit. Okay, you don't need to mug this up. You need to know that this categorization is there. When you need, look up the categorization, categorize and then treat. Don't need to mug up. Next is cervical discharge. Same kit. Painful scrotal swelling. Same organisms. The kit will be same. Now coming to vaginal discharge. Organisms like vaginal discharge can be caused by candida, that is a fungus. For that, now look over here. Ceftriaxone targets anaerobes. Vaginal discharge can also be caused by bacterial vaginosis, which is anaerobiosis. That means increase in the or alteration of the vaginal flora. For that, we need to give anaerobic ceftriaxone and fluconazole. Fluconazole is an antifungal drug targeting candida. So this kit is kit number 2 and the color is green. Next is genital ulcer non-herpetic. When I say non-herpetic, that means what? Herpes infection is treated by acyclovir. So if it is a non-herpetic, we don't need to give acyclovir. What would be the drug that is given? First is 2 kits, kit 3 and kit 4. Kit 3 comprises of benzathine penicillin and azithromycin. Why benzathine penicillin? Targeting syphilis. Kit 4 would be patients who are allergic to penicillin. You have to, if you are giving penicillin to any patient, you need to take proper history, and if the patient has allergic to penicillin, what will you do? What would be the best treatment of syphilis if the patient is allergic to penicillin? The best in all scenarios would be desensitization and to desensitize the patient to penicillin and give the penicillin. But that is not possible in a field. So next alternative would be to give doxycycline. Okay, so if the patient is allergic, you have to give kit 4. Now if the ulcer is herpetic, what you need to give? Acyclovir. For that we have the kit, the red colored kit or kit 5. It contains acyclovir 400 mg for 7 days. Next is lower abdominal pain. Here we are looking at pelvic inflammatory disease. So what were the drugs? It would include cefixime, metronidazole and doxycycline, covering all the bacteria. Just look over here, This is for 14 days. So you need to educate and counsel the patient to continuously take the drug for 14 days. Okay. Next is inguinal BO, that is swelling in the inguinal region. The kit is 7 black color. It targets what? Azithromycin and doxycycline for 21 days, which will cause inguinal BO. LGB, syphilis, and chlamydia trachomatis. So azithromycin and doxycycline for 21 days. Remember, the last two kits are given for 14 days and 21 days. So the patient must be counseled to take the drug for that long period of time. Okay. Now tell me, have you understood the syndromic approach? To understand the syndromic approach, this one chart is enough. But you need to understand why this chart has been made and how to implement it. Okay. Moving on to the next important part is antimicrobial susceptibility test and its uses. How to report. Okay. Now, coming to the treatment can be either empirical, preemptive, or definitive. What is empirical treatment? Empirical treatment means when you don't know the cause of the disease. Okay. Patient has come, we have understood that this might be a cause of the disease. Okay. For example, let us say a 60-year-old male comes with a history of cough, expectoration, fever, and on examination you can find decreased breath sound in a particular right or left side of the chest with increased rate of respiration. So you are probably thinking of this could be a pneumonia. Now you don't know which organism has caused pneumonia. How will you give, you need to initiate treatment. How will you initiate treatment? You have done all the investigation, you are advised for an X-ray, you are advised for a sputum examination. Now you need to give the treatment. How will you treat? You have to know what are the common causes of pneumonia in the local region where you are finding the case. What are the most common organism, right? For example, if this was a case of UTI, most common organism will be E. coli. You will be targeting your treatment for E. coli. That is called as empirical treatment. Okay. Then what is preemptive treatment? Preemptive treatment is, it is not a microbiologically confirmed, but we have got some evidences of infection. For example, in case of UTI, there is a particular test we can do called leukocyte esterase test and nitrate test. Leukocyte esterase test means there is presence of high quantity of pustules or WBCs in the urine. Nitrate is given when nitrate producing bacteria are present in the urine. These two will indicate an inflammatory process due to a nitrate producing organism. That means it is very highly that there is an enterobacteriaceae. Then we are considering that this is a high probability that this should be a E. coli infection. This is called as preemptive treatment. Okay. Next day you get the culture report which says growth of E. coli seen, and the laboratory have also given antimicrobial susceptibility test report that says this particular strain of E. coli is susceptible to A, B, C, but resistant to XYZ antibiotics. Now you have a definitive microbiologically confirmed report. Now you can definitively say, I will prescribe the patient A, B or C antibiotic. Have you understood? This is how the treatment works. The first is empirical, then is preemptive, and finally is definitive. So antimicrobial susceptibility test report interpretation comes under definitive therapy. Okay. So what would be the goal of the susceptibility? There are two goals. First is to give a definitive treatment. Second goal would be we need to monitor effectiveness of the treatment. Why? Because whatever test we are doing, were done in the laboratory. That result may or may not reflect in the patient's body. This is the reason why you might find many times a report will say it's an in vitro report only. In vitro means in the lab, and when we are talking about the patient, that is in vivo. Now all the tests regarding antimicrobial testing are divided into two parts. Tests which predict effectiveness of therapy and tests which monitor the effectiveness of therapy. Try to understand the difference between these two. First is prediction of effectiveness of therapy, and second is to monitor the effectiveness of therapy. That means a patient with a suspected infection, you are thinking of prescribing the patient say a particular antibiotic, let's say cefixime. So you will ask the question, will cefixime be effective in this case? That is the first question. If it is effective, then only you will prescribe, otherwise you will not, right? That is called as prediction of effectiveness. This is done before therapy. Now a test result shows that it will be effective, and you have given the antibiotic to the patient. What would be the next question? I have given the drug. Is it working? For that we need to test which monitor the effectiveness. Have you understood these two parts? The tests which predict the effectiveness are, first is MIC, disc diffusion, gradient diffusion, or growth curve detection. For monitoring effectiveness will be molecular detection, MBC, bactericidal titer, and antimicrobial levels. Now let us look at all these things, but before that, all these tests are standardized. It's not like that आज मुझे जो लगा मैंने कर दिया. You have to follow some standards. So every laboratory will follow some standards. Most commonly followed standard is what is known as the CLSI guidelines, Central Laboratory Standards Institute, it's an American guidelines, or UCAS, that is the European guidelines. Many countries like the British and the German and the France, they have their own guidelines. As far as India is concerned, we don't have a standardized guidelines till now. All over India, we either follow the CLSA guidelines or the UCAS guidelines. Commonly, CLSA guidelines are followed, as far as my experience and my opinion is concerned. Now, let us look at all the tests. Very commonly, you will see AST report is sent based on the type of test that I think this has been taught to you. This is called as disc diffusion test. The concept is very simple. On the agar plate, we put a disc containing antimicrobial agent. The antimicrobial agent will diffuse out, and we are putting the suspected organism in culture. The edge or this edge is the zone of inhibition. That means from here no growth is seen. So this is the zone at which now the antimicrobial concentration will be highest near the disc and will go decreasing as we move away from the disc. Now this is the zone that is the lowest drug concentration which is inhibiting the organism, are also called as MIC or minimum inhibiting concentration. Okay. What is the exact concentration? We cannot say from this diffusion. We need to measure from the agar. That means we need to cut a block of agar at that zone and to test it how much concentration is there. That is not practically possible. These tests are done by the CLSI and we interpret based on the zone of inhibition. Whether if the zone is larger, that means at a lower concentration the bacteria is inhibited. If the circle is smaller, that means what? Higher concentration of drug is required for inhibition. Based on the zone, we report is either sensitive, intermediate or resistant. Next would be MIC, that is done by broth dilution. Over here we take specific concentration of drug in suspension and we put a specific concentration of organism. And then we look for at which concentration the growth of organism is inhibited, by which we can know the exact concentration of the MIC. Another method which is used, which is called as e-test. Now, why e-test is used? See, dish diffusion is very easy to do in lab and interpret. Whereas broth dilution is a very tedious. For every concentration, you need to do separate test. So it's a very laborious. Easier alternative is this e-strip. Now, what is different over here? Earlier, we were using a disc containing exact amount of drug. In this strip, the concentration of drug slowly increases from down to up. So, the organism will be inhibited. This is the point where the growth is inhibited. And we can know the exact concentration which the drug is inhibited. Okay. And now, most of the laboratories will have automated system. Obviously, with the technological development, manual labor has been replaced by automated machines. They do the broth dilution and will give you the exact MIC. Based on that MIC, we can prescribe particular antibiotics. Now, coming to effectiveness of therapy, we can go for molecular detection, whether any resistance gene is present or not. Or we can do what is known as MBC, that is minimum bactericidal concentration. You do understand the difference between MIC and MBC? Yes or no? See, look at this chart. MIC means inhibitory concentration. Say we take 20 bacteria in a solution. If there are no antibiotics, what will happen? After some time, the 20 bacteria will become 40, 80, 100, it will go on increasing. Now we start putting antibiotic at various concentration. If it is very small, what will happen? The bacteria will grow even in spite presence of antibiotics. The more we increase the concentration, there will come a point in which the bacteria is not dying but can't replicate. This is called as MIC. That is, growth is inhibited. When we take out the antibiotic, the bacteria will grow further again. But if we keep on increasing the concentration of antibiotic further, what will happen? A concentration will come by which all the bacteria are dead. Forget about replicating, they are dead itself. That is called as minimum bactericidal. Cidal means lethal, bactericidal concentration. So look at this diagram. We are increasing the concentration. Over here, the bacteria is not growing. But if we take it out, put on a culture plate, we can find growth. That means the organism is living. But at this concentration, when you put up the culture, there is no growth. That means all bacteria are dead. Why this is important? Because people who are not immune compromised, what happens in their body? The body is trying to contain the infection, but the organism is replicating at a rapid pace. And when the body cannot contain, we get the disease. But if we give the antibiotic, what will happen? Replication of the bacteria will stop. The body's own immune system will then take up and the patient will be cured. That is, with the help of antibiotic, we are tilting this balance or this fight in favor of the human body or the patient. Now you must ask the question, if the patient cannot mount a fight against the bacteria, what will happen? You are giving the drug, bacteria is not multiplying, the patient is apparently symptom free. When you stop the drug, the bacteria will again start to replicate. The disease will come back. For that, we need to go at a higher concentration than MIC. Which of these patients are? Especially we will see when patients in ICU with various types of infections who are being given systemic steroid infections, people with advanced HIV infections, they will not be able to mount significant. For them, we need to know the MIC. For example, if you get infected, you are not even compromised. Standard dosing is sufficient for you. But if a patient is in ICU under steroid, standard dosing will not be sufficient. Now we need to know the MIC so that we can titrate the dose which will remain higher than the MIC. Otherwise, we will be fighting a losing battle. This is the importance of automated testing in microbiology. Okay, coming back to monitoring effectiveness of therapy, we can also test what is the level of antibiotic in the serum, not only for therapeutic benefit but also for effectiveness. And finally is synergy testing. Sometimes based on one organism may be resistant for one particular of antibiotic, but if we give two antibiotics with a different mechanism of action, it might be effective. For example, in case of enterococcus, it has got a very high thick cell wall. Okay. Many a times you will find it is resistant to say ampicillin, it is also resistant to gentamicin. Gentamicin is a protein synthesis inhibitor and ampicillin is a cell wall inhibitor. Okay. In isolation it is resistant to both, but when given together we can find a synergy. Why? If gentamicin enters into the bacteria, it will stop the protein synthesis. Stopping protein synthesis will result in stopping production of cell wall. If production of cell wall is stopped, ampicillin will act. The more ampicillin acts, more gentamicin enters. This is called as synergy. Many drugs will have synergy. We can test for synergy also. Like we can see over here, this is a D phenomenon that can be seen in case of synergy. Look over here, two discs are there. When both drugs are coming in contact, we can see a separate zone of inhibition. This is called as synergy. CLSI has categorized drugs into group A, B, C, U and O. A means all the antibiotics which should be tested and reported primarily. B is selectively. C is supplemental testing. Why this is important? Because all antibiotics are not reported. There are some first line drugs, there are second line drugs and there are reserve drugs. Why it is being kept there? First line drugs are tested for all patients. If all are resistant, then only we test for second line. If all second line are also resistant, then only we report the reserve drug. The whole purpose is to stop the misuse of drug. If you use the reserve drug earlier, it will become resistant, then the condition we are now facing with multi-drug or pan-drug resistant organisms. Okay. Classic reporting can be seen in two ways: sensitive, intermediate, resistant. What does this mean? Sensitive means the organism is inhibited by achievable concentration when recommended dose is given, which will ultimately result in a likely clinical outcome is efficacious. That means with the standard dose the infection can be cured. This is what sensitive means. What will resistant mean? That means to achieve cure, the concentration that is needed we cannot achieve by recommended dosing. What is intermediate? The concentration that is required is higher and it can be achieved only in specific areas. For example, you test a urine sample. Okay, for a particular drug, it comes as intermediate. It will mean that if the organism is present in the blood, we will not get the same concentration by recommended dose in the blood. However, if the drug gets concentrated in the bladder to the kidneys, that is secreted by the kidney, what will happen? In the blood, the concentration will be higher than that is in blood. So, if the infection is in urinary tract, now the antibiotic will be efficacious. Have you understood this or not? ঢুকেছে মাথায় না সেনসিটিভ মানে কি সেনসিটিভ মানে হচ্ছে রেকমেন্ডেড ডোজ যেটা আমরা দিচ্ছি তাতে যা কনসেন্ট্রেশন অ্যাচিভ করছে সেই কনসেন্ট্রেশনে ব্যাকটেরিয়াটা ইনহিবিটেড হবে, তাহলে আলটিমেটলি কী হবে, পেশেন্ট কিওর হবে। রেজিস্ট্যান্ট মানে কি, রেকমেন্ডেড ডোজে যা কনসেন্ট্রেশন অ্যাচিভ করবে দ্যাট উইল নট বি এনাফ টু ইনহিবিট দ্য গ্রোথ অফ দ্য অর্গানিজম, তাহলে কী হবে, লাইকলি ক্লিনিক্যাল ফেলিওর। হোয়াট ইজ ইন্টারমিডিয়েট, the required concentration is higher, কোথায়, only in particular areas where it is concentrated। এবার এইটা কিসের উপর আমরা ইন্টারমিডিয়েট দেবো তাহলে, based on the antibiotic and based on the organ system. Some of the organ antibiotics will be excreted to the kidneys, so the concentration will be higher in the urinary tract than in the blood. Some of the antibiotics may be excreted by the hepatobiliary system. If you give that antibiotic for urinary tract infection, there will be therapeutic failure. এটা বোঝা গেছে। এবার আরেকটা হচ্ছে susceptibility dose dependent, that means organism inhibited by achievable concentration when a different dose is given. কিছু অ্যান্টিবায়োটিক আছে তুমি যত ডোজ বাড়াবে তার এফিকেসি বাড়বে, ঠিক আছে, বিকজ অফ ফার্স্ট পাস মেটাবলিজম। ফার্মাকোলজিতে যদি পড়ে থাকো বুঝতে পারো, ফার্স্ট পাস মেটাবলিজম, ফার্স্ট অর্ডার কাইনেটিক্স, সেকেন্ড অর্ডার কাইনেটিক্স যেগুলো ছিল তাতে কনসেন্ট্রেশন বাড়ে, সেখানে তুমি যত ইনিশিয়াল কনসেন্ট্রেশন বাড়াবে আলটিমেট কনসেন্ট্রেশন হাই হবে, দ্যাট ইজ কল্ড অ্যাজ সাসেপ্টিবিলিটি ডোজ ডিপেন্ডেন্ট। These are the predominant 5 interpretation that you should know. Now let us look at the report. What are the constituents of the report? So this is the representative report. First is initial, that is the name of the patient, patient's identification, age, what is the sample, how the sample has been taken, what is the like look over here, what is the date and time of collection, when it is received, then what are the specific tests that has been requested for, and what is the current antibiotics or treatment that the patient has received, that is also important. Then how the sample is taken, all this has to be mentioned in this report. Look over here, patient's current antibiotic status is unknown, sample is urine, it's a clean source, and culture is indicated. All these details have to be there in the report, otherwise it's not a valid report. Next part is other ancillary tests, for example urine culture. If you just take a urine sample and put a culture, whatever growth comes and you give a susceptibility report, it does not mean anything. You have to give the ancillary findings like microscopic findings. That is the reason why we always tell that whenever a sample comes, take a microscopic look, whether it is actually representing an infection or not. That should also be there in your report. Microscopic finding. What could be the microscopic finding? Whether a microorganism is seen in the urine or not, whether pus cells are seen or not, whether there is red blood cells or not, that is hematuria is there or not. Okay. Then the culture report might be either positive or negative. So let us look at a negative report over here. Negative, the count is very low, that is non-significant count, and also we must also mention the technique by which the culture has been done, whether it's a conventional technique, automated technique, whatever method that is used, that should also be mentioned. Now let us look at a positive report. Over here it's a final report, it says type of the sample urine, report is positive, growth is seen, and the antibiogram is given. If MIC is tested for, we are giving MIC, and representatively sensitive, resistant or intermediate report is given. Sometimes more than 2 organisms may be present. It may be there, co-infection may be there. So both the organisms has to be mentioned, like over there, result 1, first organism, result 2, second organism. Then we give the susceptibility testing of result 1 and result 2. Having read this report, দেওয়া হতে পারে, না দেওয়ার কি আছে, এতদূর বুঝতে পেরেছো তো? এবার তোমাকে যদি একটা রিপোর্ট দেওয়া হয়, ধরো এই রিপোর্টটা আমি তোমাকে প্রিন্ট করে দিলাম, দিয়ে বললাম যে ইন্টারপ্রেট দ্য রিপোর্ট, তুমি কি বলবে? ফার্স্ট তোমাকে দেখতে হবে যে পেশেন্টের ডিটেলসগুলো ঠিক আছে কিনা, স্যাম্পেলের ডিটেলস ঠিক আছে কিনা, মেথড অফ টেস্টিং লেখা আছে কিনা, তারপরে তুমি কি দেবে, রেজাল্টটা কী এসছে, এবং যদি রেজাল্ট পজিটিভ আসে তার সাসেপ্টেবিলিটি প্যাটার্ন কী আছে, তারপরে তুমি তোমার ইন্টারপ্রিটেশন দেবে। সাপোজ যদি এই রিপোর্টটাই দেওয়া থাকে, সাপোজ এই রিপোর্টটাই দেওয়া আছে, আমি তোমাকে বললাম যে ইন্টারপ্রেট দ্য রেজাল্ট, হোয়াট উড বি ইউর ইন্টারপ্রিটেশন? আফটার রিডিং দ্য রিপোর্ট ইউ উইল সে স্যার this is a report of a urine culture of patient ABC who is suspected of having UTI. Patient was on particular antibiotic, a mainstream urine was collected on this date, tested by this method on this date, and based on the result we can see there is growth of say E. coli and Klebsiella, both significant growth. E. coli being sensitive to this antibiotics, resistant to this antibiotics, Klebsiella sensitive to this antibiotics, resistant to this antibiotics. And having gone through this report, now I would suggest এবার এমন একটা অ্যান্টিবায়োটিক যেটা ইউরিনারি ট্র্যাক্টে ভালো কাজ করে, sensitive to both the organisms, you will prefer that drug. Based on that, I will prefer this drug as the treatment. তখন আমি তোমাকে নেক্সট ক্রস কোয়েশ্চেন করবো যে তুমি যে বললে যে পেশেন্ট আগে এই অ্যান্টিবায়োটিকে ছিল, উইল ইউ চেঞ্জ দ্য অ্যান্টিবায়োটিক? তুমি যদি দেখো টেস্ট রেজাল্টে ওই অ্যান্টিবায়োটিক দুটোতেই সেন্সিটিভ, উইল নট চেঞ্জ। ইফ ওয়ান অর টু বোথ আর রেজিস্ট্যান্ট দেন উইল হ্যাভ টু চেঞ্জ। দিস ইজ হাউ ইন্টারপ্রিটেশন গোজ। বোঝা গেছে? ইম্পর্টেন্স অফ এমআইসি তো বললাম। ওকে, ওয়ান ইম্পর্টেন্ট ইজ ব্রেক পয়েন্ট এমআইসি কোশ্চেন। এইটা আমি তোমাদের একটু বলে দিচ্ছি, পরবর্তীকালে কাজে লাগবে। অটোমেটেড রিপোর্ট যখন আসে এমআইসিতে আসে, now there comes the question which drug to choose. Suppose both the drugs are sensitive, both have low MIC, both can be given, how will you choose the antibiotic? Numbers lie, don't look at exact MIC. কিরকম বোঝাচ্ছি, look at this particular species, levofloxacin, ciprofloxacin, both quinolones, both highly effective. One has an exact MIC of 0.25, other has an exact MIC of 1. Now if we look at the cutoff MIC, that is the MIC at above which we say sensitive or resistant. Now look over here, exact MIC for this is 1 and for levofloxacin is also 1. এটা হচ্ছে কাট অফ এমআইসি। অর্গানিজমের এমআইসি কি হচ্ছে, লিভোফ্লক্সাসিনের 0.25 আর সিপ্রো হচ্ছে 1। এবার আমি যখন অ্যান্টিবায়োটিকটা দিচ্ছি, পেশেন্টটা তো অ্যান্টিবায়োটিক পাচ্ছে, হ্যাঁ, আমি যখন পেশেন্টকে অ্যান্টিবায়োটিকটা দিচ্ছি, আই এম গিভিং ইউ ফর সার্টেন পিরিয়ড অফ টাইম। থেরাপি ফেলিওরের একটা বিরাট বড় কারণ হচ্ছে ড্রাগ দিতে দিতে যদি রেজিস্ট্যান্স ডেভেলপ করে যায়। কোন ড্রাগের এগেনস্টে রেজিস্ট্যান্স আগে ডেভেলপ করবে? যার এমআইসি যত বেশি টুয়ার্ডস কাট অফ, নট নাম্বার, টুয়ার্ডস কাট অফ। তাহলে এইখানে দেখো এক্স্যাক্ট এমআইসি হচ্ছে 0.25, যেখানে কাট অফ হচ্ছে 1, আর লিভোফ্লক্সাসিনে দেখো 1, কাট অফ হচ্ছে 1। তাহলে আমি সেম পেশেন্ট সেম কন্ডিশন, একজনকে সিপ্রো দিচ্ছে, একজনকে যদি লিভো দিই, লিভোফ্লক্সাসিন এগেনস্ট রেজিস্ট্যান্স হওয়ার চান্স বেশি। একদম তো এক্স্যাক্ট, একটুখানি রেজিস্ট্যান্স ডেভেলপ করলেই হয়ে গেল, আর কাজ করবে না। সেখানে যদি আমি সিপ্রোফ্লক্সাসিন দিই 0.25 আর 1, হাউ মেনি টাইমস? দুটো ডাবল মানে 4 টাইমস। তাহলে রেজিস্ট্যান্স মেকানিজম হ্যাজ টু increase 4 times before it becomes not susceptible. ঠিক আছে, তাহলে আমাকে যদি পেশেন্টটাকে একটা প্রলং পিরিয়ড অফ অ্যান্টিবায়োটিক দিতে হয়, তাহলে আমি কোন অ্যান্টিবায়োটিকটা প্রেফার করব? যে যত বেশি দূরে, কাট অফ থেকে যে যত বেশি দূরে। ওই জন্য যদি তুমি ভাইটেক বা অটোমেটেড সিস্টেমের চার্ট দেখো, ওই চার্টটা দেখবে এরকম থাকে, সাসেপ্টেবল কাট অফ ইয়েলো, তারপরে রেজিস্ট্যান্সের দিকে রেড। তাহলে ইফ বোথ দ্য ড্রাগস ইন গ্রিন, look for the drug which is more towards the left. Don't look at the number. নাম্বার দেখবে না, কে কত টাইমস লেফট সাইডে আছে, বোঝা গেছে? তাহলে এই প্লটে কি হবে, লিভোফ্লক্সাসিন উঠবে, লিভোফ্লক্সাসিন এখানে থাকবে সামওয়্যার এইখানে, আর সিপ্রোফ্লক্সাসিন কোথায় থাকবে, এখানে থাকবে। তাহলে দুটোর মধ্যে কোনটা লেফট হ্যান্ড সাইডে আছে, বোঝা গেছে? দিস ইজ কল্ড অ্যাজ ব্রেক পয়েন্ট এমআইসি কোশেন্ট। ব্রেক পয়েন্ট মানে ওই সাসেপ্টেবিলিটি ব্রেক পয়েন্ট, এমআইসি মানে যেটা পাচ্ছি। এটাকে ম্যাথামেটিক্যালি যদি আমি করতে চাই, মানে নিজের ইন্টারপ্রিটেশন সুবিধার জন্য, তাহলে আমি কি করতে পারি, এর ব্রেক পয়েন্ট হচ্ছে 1, এমআইসি 0.25, তাহলে 1 ডিভাইডেড বাই 0.25 কত আসছে, 4। এর ক্ষেত্রে কী হবে, 1/1, 1, 4 ইজ মোর দ্যান 1, উই ক্যান চুজ 4। এটাকে বলা হয় ব্রেক পয়েন্ট এমআইসি কোশেন্ট, দ্যাট ইজ ডিভাইডিং দ্য ব্রেক পয়েন্ট বাই দ্য এমআইসি। বোঝা গেছে? সিমিলারলি আরেকটা এক্সাম্পল, এবার এটা তোমরা নিজেরা ইন্টারপ্রেট করো। ইন কেস অফ অ্যামিকেসিন, এমআইসি ইজ 4, ব্রেক পয়েন্ট ইজ 16, তাহলে ব্রেক পয়েন্ট বাই এমআইসি কত হবে, 4, আর এটা হচ্ছে 4/4 মানে 1, তাহলে অ্যামিকেসিন উড বি আ বেটার চয়েস। দিস ইজ হাউ উই চুজ দ্য অ্যান্টিবায়োটিক্স। ঠিক আছে, এটা তখনই করা যাবে যখন আমরা এক্স্যাক্ট এমআইসি পাবো। তাহলে কনভেনশনাল ম্যানুয়াল মেথডে তো আমরা কি পাই, সেন্সিটিভ, ইন্টারমিডিয়েট বা রেজিস্ট্যান্ট, তখন আমরা এটা পাই না। আন্ডারস্টুড? আরেকটা জিনিস বলা হয়, এটা একটু জেনে রাখো, দ্যাট ইজ ক্যাসকেড রিপোর্টিং। ক্যাসকেড মানে কি, স্টেপ বাই স্টেপ, বাংলা কথা স্টেপ বাই স্টেপ। ইফ সেপ্ট্রাকশন যদি সেন্সিটিভ হয়, বাকিগুলো রিপোর্ট করবো না, যদি রেজিস্ট্যান্ট হয় তাহলে সেফে পাইম, সেন্সিটিভ হলো আর রিপোর্ট করবো না, যদি সেফে পাইম ও রেজিস্ট্যান্ট হয় তখনই মেরোপেনাম করবো। উই ওয়ান্ট টু প্রিজার্ভ মেরোপেনাম, উই ওয়ান্ট টু প্রিজার্ভ সেফে পাইম। ঠিক আছে, দিস ইজ কল্ড অ্যাজ স্টেপ বাই স্টেপ, মানে যত রেজিস্ট্যান্স বাড়বে তত রিজার্ভ ড্রাগগুলো রিপোর্ট করবো, যদি শুরুতে সেন্সিটিভ থাকে বাকি ড্রাগগুলো রিপোর্ট করবো না। দিস ইজ কল্ড অ্যাজ ক্যাসকেড রিপোর্টিং। কোনটা, এইটা, এটা আরে ওটা তো অন্য গ্রুপের ড্রাগ। আরে তুমি ড্রাগ যখন চুজ করবে, ইটস নট অনলি বেসড অন এমআইসি, ইউ হ্যাভ টু লুক এট আদার প্যারামিটার্স অলসো। টিস্যু পেনিট্রেশন কী আছে, পেশেন্টের রিনাল কন্ডিশন কী আছে, হেপাটিক কন্ডিশন কী আছে, ইউ হ্যাভ টু কনসিডার আদার ফ্যাক্টরস অলসো। একটা পেশেন্টের হেপাটাইটিস আছে আর তুমি এমন একটা ড্রাগ দিলে যেটা হেপাটিক মেটাবলিজম হয়, তাহলে তো হেপাটাইটিস আরও বেড়ে যাবে। মানে দেয়ার আর ভেরিয়াস ফ্যাক্টরস অফ চুজিং আ ড্রাগ। আমাদের কনটেক্সটে আমি শুধু এমআইসির পয়েন্টটা হাইলাইট করছি। এবার সফট টিস্যু যদি হয়, কুইনোলন্স মে বি প্রেফার্ড। ঠিক আছে, আবার ডোজিংয়ের উপর ডিপেন্ড করছে। বিটা ল্যাকটেন্স হলে তোমাকে মানে সিকোয়েন্সুয়াল ডোজিং করতে হবে, অ্যামিনোগ্লাইকোসাইডস হলে তুমি একটা লোডিং ডোজ তারপর একটা মেনটেন্যান্স ডোজে সাস্টেন করতে পারো, ওয়ান্স আ ডোজিং, তার উপরেও ডিপেন্ড করবে, নট অন সিঙ্গেল ফ্যাক্টর। Okay, so what are the key components of susceptibility reporting? Is the microbial identification in the clinical context, that is the identification of the organism, the clinical context in which the test is done, the reporting, that is either sensitive, intermediate, resistant, and if MIC is given, we need to know the breakpoint MIC quotient. Okay, এটা বললাম। A clinical consideration that should be given is based on patient's history, site of the infection, ওই যে PKPD context, site of infection, both pharmacokinetics and pharmacodynamics. And finally is antimicrobial stewardship. Stewardship class হয়েছে, the whole purpose of antimicrobial stewardship is to prevent the resistance. তাহলে কিছু ড্রাগকে আমরা ইজিলি অ্যাক্সেসেবল করি, কিছু রেস্ট্রিক্ট করি, কিছু প্রহিবিট করি। Next, another report that will be associated with antibiotics is called as antibiogram. Antibiogram কি জিনিসটা? In simple terms বলছি, এই যে আমি বললাম প্রথমে এম্পেরিক্যাল থেরাপি কি, আমি জানি এখানে ইকোলাই ইউটিআইতে কমন, এই ড্রাগটা দিতে হবে। এই যে জিনিসটা আমি বললাম, there must be a scientific basis of that. What is that scientific basis? That scientific basis is antibiogram. Antibiogram, আমার হসপিটালে আমি 1 year ডেটা কালেক্ট করলাম, all the UTIs that is community acquired, not inpatient, মানে আউটডোর থেকে যেগুলো এসছে, all are community acquired. তার মধ্যে দেখলাম কি 80% is caused by E. coli. All the 80% isolates, তাদের যে অ্যান্টিবায়োটিক টেস্ট হয়েছে তার মধ্যে দেখা গেল সে নাইট্রোফুরান্টাইন ইজ সেন্সিটিভ ইন 90% অফ দ্য কেসেস। তাহলে প্রেফার্ড কোনটা হবে? নাইট্রোফুরান্টাইন। সেম জিনিস ইজ সিন ইন অ্যান্টিবায়োটিক। এখানে দেখো প্রত্যেকটা অর্গানিজমকে আমরা এইভাবে লিস্ট করি, যা যা অ্যান্টিবায়োটিক টেস্টেড হয়েছে, কটা অর্গানিজম পাওয়া গেছে আর কে কটা সাসেপ্টেবল। বেসড অন দ্য সাসেপ্টেবিলিটি যে রিপোর্টটা তৈরি হয়, দিস ইজ কল্ড অ্যাজ অ্যান্টিবায়োগ্রাম। হোয়াট ইজ দ্য ইম্পর্টেন্স অফ অ্যান্টিবায়োগ্রাম? It will decide empirical therapy and it will dictate antimicrobial stewardship direction. স্টিওয়ার্ডশিপে আমি যে বললাম কিছু অ্যান্টিবায়োটিককে অ্যাক্সেস করতে হবে, কিছুকে রেস্ট্রিক্ট করতে হবে, কোনটাকে কী বেসিসে করবে তার তো একটা এভিডেন্স চাই। দিস ইজ দ্য এভিডেন্স। ওকে, এটা জাস্ট জেনে রাখো, এটা জানার জন্যই বললাম। নেক্সট অ্যান্টিবায়োটিক রেজিস্ট্যান্স, এই পার্টটা তো আই থিঙ্ক তোমরা অলরেডি জানো কীভাবে রেজিস্ট্যান্স ডেভেলপ করে। WHO has categorized some drugs based on this is called as WHO aware classification. This has to be implemented all over the world. What is the importance of aware classification? এটা হচ্ছে অ্যাক্সেস রিজার্ভ। অ্যাক্সেস মানে যে ড্রাগগুলো ইজিলি অ্যাক্সেসেবল, ওয়াচ মানে যেগুলো রেস্ট্রিক্টেড, আর রিজার্ভ মানে যেগুলো ইউজ ইজ প্রহিবিটেড, মানে ইউজ করতে হলে দ্যাট শুড বি সুপারভাইজড। Access group means first or second choice of antibiotics, best therapeutic outcome. Watch group is indicated only in specific situation, however it should be monitored. And third group is reserve drug, that is the last resort, মানে যেগুলো আমরা বলি MDR ড্রাগে ইনফেকশন হয়েছে তখন কি করব, 1 or 2 ড্রাগসই আছে, দ্যাট ইজ দ্য লাস্ট রিসোর্ট। এটা মনিটর না, এটা মানে একদম ওয়েল ডিরেক্টেড অ্যান্ড ভেরি ওয়েল মনিটর্ড, কোনো রকম আনস্ক্রুপুলাস ইউজ করা যাবে না। দোজ আর কল্ড অ্যাজ রিজার্ভ গ্রুপ অফ ড্রাগ। আর ফাইনালি হচ্ছে আদার্স। আদার্স মানে হচ্ছে দ্য ড্রাগস হুইচ আর স্টিল ইন ট্রায়াল, স্পেশালি ইন ইন্ডিয়া অ্যান্ড আফ্রিকান কান্ট্রিজে কী হয়, সাম ড্রাগস আর ইন ট্রায়াল বাট পিপল স্টার্ট ইউজিং দেম। জিনিসটা পপুলেশনের উপর কী এফেক্ট হয়, পজিটিভ না নেগেটিভ, সেটা বোঝার আগেই রেজিস্ট্যান্স ডেভেলপ করা গেল। ঠিক আছে, সো দোজ আন্ডার আদার্স গ্রুপ। অবভিয়াসলি অ্যাক্সেস গ্রুপে ওই ড্রাগগুলোকে বেশি রাখা হবে যেগুলো ওরাল ফর্মুলেশন পাওয়া যায়, ঠিক আছে, যাতে কমিউনিটিতে আমরা ইউজ করতে পারি। তাহলে আমরা অ্যাক্সেস থেকে যত রিজার্ভে যাব ওরাল ফর্মুলেশন কমে যাবে। দিস ইজ জাস্ট segment of the total list of the drug. তোমরা যদি WHO ওয়েবসাইটে যাও, every drug has been categorized either in A, W or R based on the classification and how it should be used. Okay, this is the initiative by WHO to incorporate and implement the stewardship in almost all hospitals all over the world. ঠিক আছে।